bit of time for Q&A after each talk. So with that, take it away, Chris.
Okay, thanks, Andy. So today, thank you guys for having me, first of all. Today we're going to be talking about amputation versus limb reconstruction in congenital lower extremity deficiencies. This is our outline, no disclosures. This is our outline. We're going to talk about what are limb deficiencies, specifically what is fibular hemimelia. We'll talk about the surgical options for treatment, review the studies comparing these treatments to figure out how these patients do as children and as adults. And the real goal for the talk is to describe what happens when a patient like this shows up in the office and to go through the thought process of trying to look into the future for them to see what their life would be like with an amputation versus limb reconstruction. And while we're going to focus on limb deficiencies, I think the ideas are also applicable to other conditions where amputation versus reconstruction is debated, like congenital pseudoarthrosis of the tibia, as seen here, and the complex deformity and skin issues seen after things like infant meningococcemia. Okay, so fibular hemimelia, this is the most common long bone deficiency, but is still pretty rare. Works out to about 100 cases per year in the US, 1 in 40,000 births. In the broadest terms, the clinical features are a short or absent fibula, leg length discrepancy, and foot and ankle deformities. It has a very wide spectrum of severity, ranging from a close to normally formed leg with a small length difference to severely affected leg with deformity and shortening. It's also often associated with other conditions, including congenital femoral deficiency and proximal femoral focal deficiency, which have their own severity range from a minimally short femur to total absence of the proximal femur and hip joint. So in fact, fibular hemimelia probably isn't a distinct entity, but rather a continuum of abnormal development throughout the leg. Our own Dr. Stevens described this as postaxial hypoplasia and reported the spectrum of abnormalities on this postaxial side of the limb. This includes a short femur with excess external rotation, a hypoplastic lateral femoral condyle with associated valgus and lateral patella subluxation, absence of the cruciate ligaments with a flattened tibial eminence, a short tibia, short or absent fibula, ball and socket ankle with valgus, subtalar coalitions, and absent lateral raise of the foot. We don't think it's genetically inherited, but there are a few cases that demonstrate autosomal dominant, autosomal recessive, and X-linked transmission. Some have suggested that it may be a vascular issue based on early series of arteriograms in these patients that show abnormal vasculature, notably the absence of the anterior tibial artery and a large posterior based vascular supply. But this could also just be a downstream effect. In another early study, based on clinical observations, these authors suggested that the existence of a fibular development field that controls these specific shaded areas during embryonogenesis. So we don't fully understand what causes postaxial hypoplasia. It may be a spontaneous or induced mutation, or maybe outside influences on the limb bud during embryogenesis. The normal process of limb bud development we can see here. So the limb bud has this apical ectodermal ridge, which guides the distal outgrowth of the limb, and the zone of polarizing activity that sits at the posterior aspect of the limb bud, which guides the anterior-posterior development through the sonic hedgehog signaling pathway. In the upper extremity, posterior correlates to the ulnar side of the limb and the small digits, and then the lower extremity posterior correlates to the fibula and lateral foot. The importance of the zone of polarizing activity has been demonstrated in chicken embryo experiments looking at wing development. This is in a lot of like the basic biology textbooks, showing that if you take additional material from the zone of polarizing activity and transplant that to the anterior side of the limb bud, you end up with a mirrored limb with duplication of what in humans would be the ulnar side. So postaxial hypoplasia likely has something to do with interference in the signaling pathway early in development, and perhaps the time at which signaling goes wrong determines how much proximal femur and hip involvement there is. For classification, as we said, with fibular hemimelia, there's a spectrum of severity, and early classification systems focused on how much of the fibula was present. The group from Texas Scottish Rite classifies these based on whether the foot is preservable, which they don't define in great detail, but they describe as the presence of or the ability to provide a painless plantigrade foot. Dr. Paley would say that all of these patients have the potential for foot salvage and reconstruction regardless of severity, and his classification divides them into groups based on surgical technique. So that is fibular hemimelia, which, as we said, is probably better termed postaxial hypoplasia. Now we can go into more detail about what the treatment is like for these two pathways. The amputation option, so this is typically a cyme amputation where the foot is removed distal to the ankle joint, but the heel pad is preserved for weight bearing. And this can take a severe foot deformity and create a painless, stable weight bearing surface that also fits really well into a prosthesis. Children with this amputation seem to do pretty well. This is a frequently cited study looking at the energy costs of different levels of amputation in kids. In this figure, the dotted line is a healthy control group with the bars representing different amputation levels. And what they found was that children with amputations through the knee and distal were able to maintain a normal walking speed without increasing their energy cost. So kids with a cyme amputation are pretty comparable to normals. This study looks at the ability to ambulate without a prosthesis, which is another proposed benefit of the cyme amputation. They found that only about half of children were able to or chose to ambulate short distances like in their bedroom, and that as they age, so in that 11 years and older group, the ability or choice to ambulate without a prosthesis decreased. The study also notes some of the issues that come up in these patients, including frequent visits to the prosthetist and complications including poor fit, stump pain, sores, and foot breakage. So the arguments, just to summarize, in favor of amputation are that it's described as a one surgery option. There are fewer complications, fewer hospital stays, and it provides good function. The arguments against are that it doesn't address tibial and femoral deformity and that patients lack a sensate foot. The prostheses can be costly, and I think we don't really know the long-term consequences of these kids having a cyme amputation as adults as you enter mid to late adulthood. So moving on to reconstruction, the specific steps depend on the exact deformity, but for this Paley type C3, 3C with an absent fibula, a tibial bow, and equinovalgus deformity, you start with ankle and hindfoot reconstruction with takedown of the coalition and realignment and pinning. Then performing osteotomies to address the tibial deformity and shortening to minimize tension on the neurovascular structures. And then placement into a frame for stabilization and lengthening through a proximal tibia osteotomy. This can take a foot with a severe deformity and get it into a pretty functional plantigrade position. But that's just the first stage, right? So future lengthenings of the femur and tibia are usually required with or without contralateral epiphysiodesis, potentially the use of guided growth to correct angular deformities, and many patients will need stabilization of the hip and knee joints to prevent subluxation and dislocations when lengthening. So that process can get you from a severely deformed foot and leg to this, which I think is hard to argue is not an impressive transformation. The people who perform these operations, particularly the ones that pioneered them, are very passionate that amputation should only be a treatment of last resort. And to summarize the arguments for limb reconstruction, so it provides a sensate foot for proprioception and balance. There's the potential for normal foot and ankle motion. You don't have a prosthesis with its associated cost and inconvenience. And the arguments against are that it requires multiple surgeries and has higher complication rates. So if we take a closer look at some of those complications, most happen during the lengthening portion of treatment. And when that's done with an external fixator, there's a long list of things that can be an issue. With the introduction of the internal lengthening rod, that eliminated the issues of pin site infection and improves patient satisfaction, but there's still an overall complication rate of about 20% if you take all comers, all diagnoses. If we look closer at congenital limb deficiencies, in this case, congenital femoral deficiency, this study looked at external fixators and compared it to internal lengthening nails. And they found, like you'd expect, superficial infections were significantly lower in the internal nail group, but every other complication category showed no difference. And there was no difference in total complications, with pretty high rates in both groups, 81% in the external fixator group and 60% in internal nails, which is important information to be able to tell families. So that reviews how we've gotten to this point, kids with either an amputation or a completed reconstruction. So now we'll talk about what life is like for these patients while they're growing and as they progress into adulthood. So the first question is amputation really a one surgery treatment, which is how it is frequently presented to families? So this is a study, a small series from Texas Scottish Rite looking at patients who had a SIME amputation for fibular hemimelia, evaluating them as adults ages 19 to 26. They found that 4 patients had 6 secondary procedures, 3 cases of guided growth, 1 knee ligament reconstruction, 1 stump revision, and 1 tibial osteotomy. So including the amputation, that's 1.6 procedures per patient. This study comparing 20 amputations and 22 reconstructions found the amputation group had 1.2 procedures per patient compared to 3.5 procedures per patient in the reconstruction group. There were no complications in the amputation group and 9 or 41% in the reconstruction group. The criticism of this study is that it evaluated kids around age 8 to 10. And so there are probably more surgeries in the future for the reconstruction kids and maybe even for the amputation group. Finally, this study looked at these patients as adults at a mean age around 32. They found that the amputation group underwent 2.4 procedures per patient and the reconstruction group had 6.3 procedures per patient. There were fewer in the amputation group. So to summarize, is amputation really a one surgery treatment? It's usually not. There's often additional surgeries, which is important to tell families when they're considering the options. But these additional surgeries are usually less invasive, outpatient procedures with fewer complications. Okay, so considering that, does the number of procedures really matter? Should we just be concerned about the final result? Well, there is some evidence, at least in younger children, that multiple anesthetics can be harmful. This shows a matched cohort study comparing 350 patients exposed to a general anesthetic under age 2 to 700 controls. They found that more than one exposure to anesthesia led to an increased risk of learning disabilities and the increased risk for a need for an individualized education plan for speech, with those red arrows showing the lines for 2 or more exposures. This even larger study looked at over 11,000 patients exposed to anesthesia under age 2 with 23,000 controls. They found an increased risk of developmental delay with increasing number of exposures to anesthesia and similar findings with longer time under anesthesia. And I think this is relevant both for the amputation and limb reconstruction groups. For both treatment options, most people recommend starting somewhere between 18 and 24 months. So usually under age 2. In the amputation group, this is just a single event typically. In the limb reconstruction group, the first stage as we said, involves osteotomy and frame placement, potentially followed by a second surgery to remove the frame. And if you account for just one of those complications we discussed, you can easily get above 2 to 3 surgeries before age 2, putting them in that increased risk group. Okay, next question is, what is childhood like for these kids as they're undergoing treatment? This study looked at 15 amputations and 10 lengthenings at 2 to 15 years follow-up. The average age of follow-up for amputation, 8.2 years, lengthening at 16.8 years. So they're probably not comparing the exact same types of patients. But with this in mind, the amputations had fewer activity restrictions, better activity scores, and less pain. This was based on their own scoring rubric. This is a more recent multi-center study comparing 20 amputations with 22 reconstructions, with all the amputations coming from Texas Scottish Rite and all the reconstructions from the Baltimore group. There was no significant difference between the age of the patients at follow-up. These are their outcome measures. They found no difference in parent or child satisfaction, no difference in health-related quality of life between groups, and that the psychosocial and quality of life scores were comparable with controls. So then what about as patients age? How do they do as adults? This study looked at, compared 14 patients who used a prosthesis. And this was not a completely clean cohort. There's a mix of SIME amputations and extension prostheses, and compared it with 16 limb reconstruction patients, ages 18 to 36 years. They found no difference in physical function based on a 6-minute walk and stair test, no difference in health-related quality of life. And, but they did find that both of these groups ranked worse in function and health-related quality of life compared to healthy controls. Finally, in this largest cohort study, they compared 36 amputations with 26 lengthenings for fibular hemimelia, collecting patients from 6 institutions and evaluating them at 21 to 55 years of age. These are their outcome measures. They found no difference in self-reported education, employment, income, pain, sports and activity level, and satisfaction or appearance. The amputees did have better scores in the job satisfaction section of the quality of life questionnaire, but no difference in health-related quality of life or physical function scores. Another question is cost. This is the only study to consider this question, and it was back in 2000, so all the dollar values are from late 90s, early 2000s. They found the cost of treatment for an amputation was about $7,000, and for lengthening was $27,000. But this doesn't include the cost of prosthetics or orthotics, which has been estimated to be around $400,000 over the lifetime of a patient. So some general thoughts on those studies. They're all retrospective. They're all pretty small. The amputations universe, like just in general, the amputations were performed in more severe cases. The reconstructions were performed in less severe cases. So, you know, if you gave everybody an amputation, would they do better or worse? If you gave everybody a reconstruction, would they do better or worse? I don't think we know. And then there's no real agreement on the definition of a salvageable foot. So in summary, fibular hemimelia, better term post-axial hypoplasia, is a complex lower extremity deformity. Amputation is usually not a one surgery option, but the additional surgeries are fewer, less invasive, and have lower complication rates. Outcomes in children and adults are mostly the same between amputation and reconstruction, and it's reasonable to consider both options. In the end, like with many things, it's a discussion between the family and the physician. I think reconstruction is a reasonable choice if families are aware of the complications, and it can lead to some pretty amazing transformations. And but on the other hand, I think that amputation should be considered a reconstructive procedure that has the ability to restore function and not just an option of last resort. Thanks.
Thanks, Chris. We have some time for some questions here. If anybody has any in particular, I'd be interested to hear what the pediatric folks have done in their careers and if they've changed for any reason.
So I have a question while they're considering that more important question. My question is, can you tell us about how you stratify patients based for lengthening based on the soft tissues? We look at x-rays and see bones, but there's a few things in the soft tissues that matter a lot, like ligaments and nerves and vessels. Can you tell us about how you think about that if you're approaching a patient with lengthening options?
Yeah, so I think that's incredibly important. These kids, as you said, it's not just bone length and bone shape. It's they have abnormal soft tissues. So the soft tissues are often stiffer and can make it harder to lengthen. And as we said, you know, it affecting the whole limb, it's associated with issues at the hip, at the knee. So oftentimes these kids need ligament stabilization procedures around the knee to prevent subluxation or dislocation when you're lengthening. They need often hip reconstructions or sometimes just a pelvic osteotomy to support the hip as you lengthen. And but in terms of like looking at a patient and saying, how much can you tolerate? Like, what can you do? I think that's a little bit of more of the art than the science. I think, you know, I put this slide at the end, which goes into that categorization based on whether the foot is preservable and what to do about it. And again, they don't define what's preservable, but I think if they have a close to normal looking foot with intact ankle range of motion, some people have talked about the number of rays present, but certainly soft tissue is an important part of this too, with lengthenings being reserved for folks who have this, who may only need 1 or 2 lengthenings. I would say that from seeing these patients in follow-up, you know, I think that I would be hesitant to recommend more than 2 lengthenings to patients, because I think that at a certain point, those tissues just get stretched out and are abnormal. And even if you start with a functional ankle and knee, I think you end up in some trouble. So.
And Chris, can you say something about are there some absolute indications or contraindications for you that really just throw them into one category or the other? Like you mentioned, the number of rays in the foot or something like that, which historically had been used.
Yeah, so people have used like how much fibula is there or how many rays. And I have seen kids with a single ray have their foot preserved and do okay. And I've, you know, seen patients who have 4 rays, the families elect to have an amputation. I think a lot of it goes back to, is that, you know, your best prediction of, is that foot going to be okay when you're done? And so I think, you know, I don't usually base it on the number of rays, you know. I would say it's more based on what the foot looks like, how it moves, the range of motion. But I think that we don't know the answer to that yet.
How many of these do we see a year? How many new ones a year?
I probably don't have a perfect sense of that, but I think, you know, new patients, maybe I see 1 a month, and then Dr. Hennessy also sees them, and she probably, I would think, probably sees about the same.
And do we have records going back 50 years somewhere where we saw 1 every other month to find out the long-term outcomes?
Yeah, I think through, you know, Shriners is probably the best resource for that. I don't know how long those records go back, but certainly, you know, Shriners has the records and has the patient population to be able to look back. I think that just me seeing those kids in follow-up, most to all of those kids that were treated here at Shriners, 20, 30 years ago, I don't know if I've seen any of that soon, but 10 to 15, 20 years ago, were mostly amputation. I don't know that, and the folks who've been here longer can comment, but I don't think that people have been doing advanced reconstructions here for very long, and I think that this is a newer thing for us.
I don't think that we would have, when you talk about reconstruction that was done 20 and 30 years ago, like it's in a completely different league now, which is why I think it's important for us to have somebody, like Chris here to do this. I mean, it's completely different than it would have been, and amputation would have been the go-to so many times because people didn't understand the techniques to be able to do the reconstruction, I think.
No, the reason I asked the question is there were some, I think, valuable long-term follow-up studies from Iowa where you would take a childhood disorder and you compare them to the general population at 50 years post whatever the problem was, and see how they function in society. Did they get married? Did they have, were they employed? Were they happy? And we tracked them down. And there are companies that can help you track folks down. They didn't all live in Iowa, though it was a little easier perhaps there. But if these data are available, it could be a meaningful project if there are 30 or 40 folks that at 50 years, how their lives turned out for amputation.
Yeah, I think that'd be very valuable, and that's information that we don't have now. I think there's information of sort of the early adulthood range, but in a very small number of patients, and just seeing some of those patients back and follow up at the Shrine, I think that we have numbers to contribute to what's out there.
Okay, thanks, Chris. Any other thoughts before we transition over to Dr. Marchand?
Dr. Tischer, can I ask a question?
Dr. McClure, of course.
I think we're very grateful to have Chris have had some time with us here. I was wondering how he felt about his experience so far with trying to help patients navigate the bias in these studies, because that's the hardest thing for me. The Birch-Paley study, one of the biggest significant differences, or most dramatic, was that the reconstruction kids were doing better in school, which has, probably a background in bias. And then in some of the other studies, the reconstructions were lengthening without any joint stabilization, which is going to drive some of the multi-center studies to have perhaps decreased outcomes. So how do you go about pulling a patient family through this process and helping them figure out the best decision for them when the studies are so full of biases?
Yeah, I agree. I mean, the studies are, as we said, they have issues. I think that bringing up that education part, the reconstruction doing better in education, like that, I think that Birch-Paley study showed that the families that elected reconstruction had higher education levels and higher income levels. So maybe those kids would have done better anyway, and the opposite could be said for the amputation. I would say that in clinic, with these patients who come in as new patients, I spend a lot of time trying to talk people back from amputation who, probably because of what you're saying, just see it as a one and done operation. And so I think being able to give them information about, it's typically not a one-time surgery. You can still have issues with the femur and the knee and moving forward. And like you said, those older studies don't use the best techniques, right? Like the techniques that you guys are doing in Baltimore and the techniques that Paley's doing in Florida. I think that Birch-Paley study that shows us how they're doing in childhood, it'll be really interesting to see how those kids are doing if you can keep track of them, 20 years from now as they get into adulthood, and hopefully that'll provide us more information for like the long-term consequences of each option.
Yeah, I think we see it the same way. I think the hardest part for me is when I can feel a family making an emotional decision in either one direction or the other, because the emotional decision can pull you either way. But that's a different thing than making a logical decision, because you can arrive on either side, thinking through it carefully based on your family preferences, resources, personal impression of amputees, etc. You can go either way, and you can go either way emotionally. But sometimes, like when I feel a family being like, we just can't say goodbye to this foot, you're like, well, that's not a good reason not to have an amputation. How's that been for you in the last 6 months?
Yeah, it's been challenging. I would say that I probably have seen more of the kids who come in, and maybe it's just the population, but they come in with like a 4-rayed foot that looks beautiful, beautiful ankle, and you're trying to say like, look, I think you could do really well with a reconstruction. They're like, as you said, an emotional decision. No, like, let's just get rid of this. Let's move on with our lives. And I think, in trying to talk with families about it, what I try to do is just give them the information, and not try to influence it. Because I think what I wouldn't want to do is push a family toward reconstruction, and then they get 10 years down the line and they're resentful because their foot's not perfect, and they don't appreciate or don't, or they haven't benefited from what we did for them.
Birch has a very dramatic story about that. You should ask him sometime, but I think there's a great presentation. Everybody's lucky to have you out there, and thanks for hanging out with us for a few months.
Yeah, thanks, Phil. Thanks for having me.
All right. Thanks, Phil, for chiming in. Appreciate it. Good to hear you. We're going to move on to Dr. Marchand now, if you're ready, Lucas. Thanks again, Dr. Makarewich.
Yeah, awesome. Thanks, Chris, for kicking off hour-long grand rounds here. So I would just want to say really quick, because I'm going to be right up against it time-wise from when I've practiced this talk, that I'm giving this talk to another department in a couple months here. And so if I miss people at the end that have any sort of feedback, I welcome it. Either call me or email me. I'd really appreciate it. So excited to spend the next hour talking to everybody, or the next half hour talking to everybody. And thanks to the department. I'm going to share with you a lecture I have titled High Impact Research in Orthopedic Trauma, a review of the literature and lessons learned. No relevant disclosures. I'm still working on this. When Dr. Tischer asked me and Dr. Makarewich to give a talk today, he said that we could sort of use this moment and this platform as a plug for our own practice about something that we do unique or different, or a part of our practice that we want to build. But for the most part, as you all know, trauma is a copycat league, and I pretty much do everything like my partners, and we spend the day making one side look like the unbroken side. With the exception of the fact that I like to fix hip fractures and nail femoral shaft fractures in the lateral position, or maybe my tendency to fix olecranon fractures with an intermedullary screw, I pretty much do everything like everyone else in my division, and I'm interested in the same stuff. But that doesn't mean I'll let the moment slip away for a shameless plug. If you ever have any fractures, non-unions, malunions, infected fractures, infections, or research topics you want to talk about, this is for the whole department. Obviously, my office door is always open when I'm in there. I'm always available to talk via phone. So get a hold of me whenever, however, happy to discuss these things. So what are we actually going to talk about today? We're going to cover research ideology, and that will just sort of be some of my random thoughts with Lucas about research. And then we're going to go over what is high impact. This is like a term that I think gets used, or it's a term that I use, and we're going to cover what I think it means to me. We're going to go over clinical trials and specifically randomized controlled trials and the benefits they provide us in answering important questions. And then we're going to go over some of the preeminent publications in orthopedic trauma that have been performed through randomized clinical trials and learn clinical lessons that you can apply to your practice. But more importantly, the bend of this talk is to teach some research lessons that maybe you can incorporate into your career. Overall, this is not going to be an exhaustive talk. So I'm definitely not going to cover every important randomized controlled trial that's been published in the realm of orthopedic trauma, but I'm going to try to pick some that I think teach a specific point to everyone in attendance today. To start the talk, I think it's important that we all reflect about why we do research. So the reason that the residents do research, which may be for a graduation requirement, is different than the tenured professor. And I'll just share with you why I do research. I do research for what you see on this slide, which is my patients. Absolutely, I enjoy the process of discovery, but I do research because I want to try to make the outcomes of my patients better, and more importantly, the outcomes of other surgeons' patients. This is the one way where you can have an effect on somebody's outcome, but not actually have your hands on that patient. And to me, that is what is so cool about research, right? You can have far-reaching effects beyond your own clinical practice. We should quickly address the elephant in the room, which is that I'm the most junior faculty member in the department with the fewest publications, and I'm up here trying to talk to everybody about research. I have some insight into that. I'm not trying to tell anybody how to do research, but rather share some things with you all that I learned in this sort of extra 6 months of a fellowship I did. So what expertise do I have in the realm of research? Well, as everybody knows, I did residency here, and then I went on to do fellowship at this hospital in downtown Baltimore, shock trauma. And two of my mentors on the left-hand portion of this slide, Bob O'Toole, and on the right-hand portion of this slide, Gerard Slobosian, I would consider kind of the forefront, smartest people in orthopedic trauma research. And I think publication numbers and research dollars and all that would sort of support that claim. If they're not at the top, they're both very near the top. And so these two were able to convince me to stick around for 6 extra months after I finished my clinical fellowship to do a quote unquote research fellowship where I essentially took call 1 night a week at shock trauma, took some master's level courses at the University of Maryland, Baltimore, and then worked with these guys on a daily basis, thinking through research problems and watching them run big prospective randomized controlled trials. They have contrasting philosophies when it comes to research. So Dr. O'Toole would tell you, you should do all the research, Lucas. You should write up case reports, and you should do case series, and you should do retrospective cohort studies. And then you should do prospective randomized controlled trials of 1,000+ patients. And Slobosian is sort of on the other end of the spectrum. You should, Lucas, only do practice-changing research, high-impact, prospective type studies. And after spending 6 months with these guys, I would tell you that I think the truth lies somewhere in the middle. And this is for the residents who are going to go into academics or the early career faculty. You have to do some of the smaller stuff, some of the case reports, the retrospective cohort studies to understand how to do research, to build a CV, to get funded, to then do some of the bigger high impact stuff. But if you spend your whole career just doing the smaller studies, you may not have that one big publication you want that will sort of change practice and leave you some sort of research legacy. So what does it mean to be high impact? For me, it means practice influencing or practice changing. This has to be something typically novel or universally important that maybe shifts the paradigm of current dogma or really enlightens us and gets us thinking about a problem in a new way. But this is maybe the most important slide in my lecture. High impact publications, in my opinion, are not always clinical trials. And in fact, in orthopedics, they very rarely are. And particularly in orthopedic trauma, most of the decisions we make on a day-to-day basis are not centered around the outcomes from a randomized controlled trial, but rather a retrospective review. And one of my favorite examples to illustrate this point is the publication by Dr. Baumgartner, who's out of Yale and one of Dr. Higgins' former mentors. This really clever idea of the tip apex distance, I would submit to you, has changed the way hip fractures are managed across the country and probably across the world. Because I bet there's not an intertrochanteric femur fracture that gets fixed at an academic institution and even outside of one where the surgeon is not at least thinking about tip apex distance, if not outright talking about it. All right, they were able to predict failure of these injuries through this really clever retrospective study. But it takes an incredible idea, a very clean idea, a project that's amenable to retrospective review, and an appropriate data set to have a high impact publication through a retrospective study like that. That was an extraordinarily novel idea by Dr. Baumgartner, and that's really why it changed practice. Which brings me to why clinical trials are so important. The results of these studies we would often consider high impact because this is the gold standard in clinical medicine. So we all know Kevin Jones. He's used to performing experiments in a lab on a benchtop, right? Where he has control over almost every variable in his experiment. And then what he does is he changes one variable and he sees how that one change affects the outcome of his study. In clinical medicine, the closest we get to just changing one variable and keeping everything else the same is a randomized controlled trial, which is why it's such a powerful instrument for us. And there are a number of factors that make randomized controlled trials useful and have made them the gold standard. One of which is that it creates balance of unmeasured factors, which goes without saying that it eliminates unmeasured bias. So in other words, let's just take the ability to cope with a problem, right? This is a very hard thing to measure in clinical medicine. It's particularly important in orthopedic trauma, but even amongst many of the subspecialties in orthopedics. It's difficult to measure, and because of this, we can't really. But if we're running a randomized controlled trial, we hope that sort of the quote unquote ability to cope between patient groups would be balanced through the process of randomization. Some people will describe this as Z factor. Randomized controlled trials are the closest thing we can get to the truth for this reason, and therefore we can trust the results, which is why I think they become high impact, quote unquote. And finally, they allow us to assess causal effects as opposed to associations, which is the conclusions we come to in retrospective reviews. X is associated with Y, whereas in an RCT, you can come to the conclusion that X is causing Y. So having made the case for why RCTs are the gold standard experiment in clinical medicine, why they're so important, let's start reviewing some of the randomized controlled trials that have been done in orthopedic trauma and see what we can learn from them from both a clinical and research standpoint. RCTs have been happening for a long time in orthopedic trauma. And here's a list of a bunch of RCTs. I don't expect you to read the title of every study. Suffice it to say that many of these studies are still impacting care today, particularly that article in the lower right-hand portion, early versus delayed stabilization of femoral shaft fractures, has really changed the way we've managed polytrauma patients. And you see that these studies date all the way back to the late 80s. So we've been doing studies like this for a long time, but the cohort size in these studies really pales in comparison to other fields of medicine like cardiology or even rheumatology. Furthermore, this 2002 JBJS publication looked at the quality of the randomized controlled trials published in orthopedics up until that point. So from 1988 to 2000. And they said many of these trials, while they're well designed, are limited in a number of regards, such as the lack of concealed randomization, the lack of blinded outcome assessors, unclear patient exclusions, and for the most part, they were underpowered. Power is an interesting thing because some people would say if you detect a statistical difference, then the power of your study matters less because the stats told you there was a difference between the two groups. But in my opinion, that's only really true if your study was powered, and we're going to drive that idea home with a couple of papers throughout the talk. Less N, or a smaller cohort, typically means more fragility or less robustness to your study, however you want to describe it. And this point is driven home by this 2019 Journal of Orthopaedic Trauma publication, where they reviewed the fragility index of fracture-related publications from the Journal of Bone and Joint Surgery and the Journal of Orthopaedic Trauma over a 22-year study period. And what you can see squared in the slide that you see here is that in all of the RCTs that were fracture-related, in those two, which we would call the preeminent journals for the most part, for orthopedic traumatologists, the fragility index was 4. And what the fragility index is measuring is the number of patients in those controlled trials that would have had to flip from one outcome to the other outcome to flip the results of the study. So really a scary thought. 4 patients would completely change the conclusion of your study, which I think tells us the importance of power. Beyond that, having a small cohort size makes it difficult to study rare events or to study small differences in outcomes, right? That's the beauty of power, is that you can detect, or larger study size, you can detect smaller differences. So while size isn't everything, this is our first research lesson. A larger cohort or a larger N lets you detect smaller changes or investigate more rare problems and may improve the robustness of your study and increase the number that is the fragility index. But these are really the historic RCTs that were run in orthopedic trauma. I would say over the last 2 decades, we're in a quote unquote new era of investigation. And this all really started with the 2008 JBJS publication, the SPRINT trial, which was a randomized trial of reamed and unreamed intermedullary nails and tibial shaft fractures. I'll tell you that in modern times, I think many people think of this trial as uninspiring because they think the idea wasn't that interesting. For me, this trial, and for many reasons, had the exact opposite effect. I find it sort of inspiring. The driving force behind the SPRINT trial was this gentleman, Mohit Bhandari, who literally wrote the book on evidence-based orthopedics. So not just in trauma, but in all of orthopedics, he wrote the book. So he knows a thing or two about running clinical trials and research and investigation. There were 2 separate publications, both smaller randomized controlled trials, looking at reamed versus unreamed tibial nailing and open and closed fractures that both showed a slight benefit towards reaming, but neither of which was definitive. And so these 2 trials, Dr. Bhandari felt like, generated equipoise and interest in the topic. So the results of Dr. Bhandari's curiosity at the time was publishing the largest randomized controlled trial in orthopedic trauma. So they randomized just over 1,300 patients to reamed versus unreamed tibial nails, looking at the primary outcome of bone grafting, dynamization, or implant exchange. So essentially a bone healing procedure at the 1-year mark. And they found no difference in primary outcomes, which is maybe why people find the results of this study uninspiring, because it was essentially a negative trial. Fortunately for us, there is a clinical take-home here, because in the trial, surgeons were forbidden from operating on a tibial shaft fracture prior to 6 months unless it was planned. So if you broke your tibia and at 3 months, it didn't look like you were filling in with callus, but none of your hardware was broken, you didn't have a catastrophic failure, you weren't allowed to take that patient back until 6 months to perform some sort of procedure. And it turns out a bunch of tibial shaft fractures healed between the 3 and the 6 month mark, which is something we did not previously know. And because of that, the event rate in this study of the primary outcome was much lower than what had been historically published. So this absolutely changed practice. Second research lesson. Because of this trial, there's always something to learn. And anytime you have 1,000 patients that you've prospectively collected data on, there's probably a lesson to be learned somewhere in there. And just let the results of the trial speak for themselves, right? This was a negative, a negative trial result, but it doesn't necessarily mean that it didn't bring us any closer to the truth, right? That probably is the truth for the most part. On the heels of the success of the SPRINT trial came what was, again at the time, the largest RCT in orthopedic trauma, the FLOW trial, which is a trial of wound irrigation in the initial management of open fractures. And you know that this trial was a big deal because if you look in the upper right-hand portion of the slide, it has its own logo. I think as the kids say nowadays, #goals, right? Like if you run a study and the study has a logo, you've made it in life. But back to the study. So this was a 2x3 factorial design randomized trial looking at irrigant solution and the pressure of that solution applied to wounds. So they looked at Castile soap, compared that to normal saline, and then both of those irrigant solutions at 3 different pressures. So what they considered low, high, and very high pressures with corresponding PSI that you see here on the slide. So both solutions get that. And this is a Herculean effort. At the time, I think some people would have said this was impossible to execute in orthopedics. Almost 2,500 patients randomized amongst essentially the 5 groups. And you see here equitable distribution of the patients in each group because the process of randomization worked. Looking at the primary outcome of reoperation for wound or bone healing complications up until the 12-month mark. Ultimately, the study found no difference in the reoperation rate at 1 year depending on or per pressure type. However, the study did favor saline over soap. So clinical take-home, low pressure irrigation may be a cheaper and equally effective way to irrigate wounds, but most likely you should be using, and I wouldn't even say most likely, I would just say you should be using normal saline in these wounds based off the results of this trial. This study taught me one thing, and hopefully if you had to leave this lecture with one thing to take away from it, it would be this: to think big. I believe that many people prior to this investigation would have said investigating or researching the effect of an irrigant solution on the reoperation rate of open fractures is technically impossible. And how many times have you guys stood in a room as a resident and heard an attending say, well, we'll never know the answer to that? That is just not true unless that question is simply not worth the investment in terms of investigation. If it's a big enough problem, we can find an answer to it, which is what is cool and what I think Bhandari has inspired amongst many people. And I'm going to take a moment here to drive home our research lesson number 1 regarding the power of study using data from the flow trial. So this is a secondary analysis paper where the authors of this work analyzed the flow data in 250 patient increments. So as you work from the top to the bottom of the diagram you see on this slide, that's just if the primary outcome had been evaluated at 250, then at 500, then at 750, then at 1,000 patients, and so on and so forth. And what's so cool about this, as you can really see the effect of study power and sample size here. Where at the very start of the trial, had the trial ended prematurely, we would have come to an erroneous conclusion that actually there was no difference between the soap and the normal saline group. But as you see, as that N gets bigger, the confidence intervals shrink, we hone in on the truth, right? And it takes us about 1,500 patients to where we come to the correct conclusion that saline is actually better. And then again here, we determined there was no difference between the pressures used to irrigate the wounds, but you do see again the confidence interval shrinking as we really dial in on what the truth of the study is. So here's a subsequent large prospective randomized controlled trial, the FAITH trial, another effort out of McMaster's University in Canada, looking at low energy hip fractures in patients over the age of 50. Where the 2 cohorts were randomized to either sliding hip screw or a cancella screw construct. Again, you see here, over 1,000 patients enrolled in this trial. Unfortunately, I don't have to read past the first line in the first table to draw a conclusion from this study, nor does anyone attending this lecture via Zoom or in person. Because the average age of patients in this study was 72 years, just over 72 years. I don't think anybody in here is likely considering a fixation construct for a 72-year-old with a displaced hip fracture. So the clinical lesson we learned from this trial is that there was no difference in the reoperation rate between the 2 groups, but the reoperation rate was not surprisingly high. So a 4th research lesson for us, your study needs to include relevant treatment and outcome data. While the outcome and the treatment strategy in that study may have been applicable around the world, for us in North America, where that study mostly happened, I would say that's just not the way the patients were being treated. So it's hard to take a lot away from that paper. And it's really hard to swallow that after you've invested so much effort into randomizing over 1,000 patients and then realizing that your study's not all that applicable across the country or to the patient population that people are typically managing. And so I'm going to spend the last couple minutes here driving home my fifth and final research lesson for everybody. This is going to come from some data that's not yet in print, but hopefully on its way to print, but was presented at the 2018 Orthopaedic Trauma Association. So this is another multi-center RCT looking at the intra-wound application of vancomycin powder and reducing surgical site infection after fracture surgery. So you can see here, my former mentor was the PI of this study, and they wanted to know in high-risk orthopedic trauma wounds, so basically periarticular tibia wounds, plateau and pilon, does vancomycin powder decrease your chance of getting a surgical site infection? Nearly 1,000 patients randomized to either receive vancomycin powder in their surgical site at the end of surgery or not. And they demonstrated a 50% reduction in the surgical site infection rate when vancomycin powder was applied to wounds. But when you do the statistical analysis and you compare the two groups, you get a p-value of 0.07. This is a tough result to interpret for many people and a really tough result to explain in a manuscript. So which side of the line do you fall? How would you interpret this? Does vancomycin work or does it not work? And I think everyone's thinking, Lucas, it's not that black and white. There's levels to this. And I would push back and say, in fact, it is that black and white. Because at the end of the case, you're either gonna put vancomycin powder in your wound or you're not. And it all depends on how you interpret the results of this trial. So this is something I was interested in. And I leveraged the power of a separate prospective RCT that I'm a part of. And we looked at nearly 5,000 fracture cases to see how frequently antibiotic powder was placed in wounds at the end of surgery. And mind you, this is on the heels of that 2018 OTA presentation. Turns out about 1/3 of the time surgeons were placing vancomycin powder in their wounds, but that's for all fractures. What if we just look at those fractures that they were actually investigating in the Vanco trial? So periarticular tibia fractures, that number doesn't change much. It goes up 2%, still about 1/3 of cases, right? Very interesting, the two highest enrolling centers in this prospective trial were placing vancomycin powder in wounds at extraordinarily different rates. One center, 90% of the wounds, fracture wounds, were getting vancomycin powder. At the other center, less than 10%. Which leads me to believe that the treating providers at those two centers saw this p-value, because I know they were at the Orthopaedic Trauma Association and I know they saw that presentation. They saw this p-value and they came to the exact opposite conclusion, which is totally fascinating, right? And it lends itself nicely to some statistical humor about Bayesian versus frequentist statistics, but we'll just leave that for another day because that's a whole topic on its own. I can only tell you how I interpret this p-value, all right? So while the p-value doesn't reach statistical significance via traditional means, I read that p-value and think that there's a 93% chance that the 50% surgical site infection risk reduction is a real finding. And that in this clinical trial, there's biological plausibility as to why there would be less infection when vancomycin powder is applied to wounds. And because vancomycin powder is cheap, and because the local application of vancomycin powder has minimal clinical downside, for me, vancomycin powder is a winner and you should be putting it in your wounds, at least in periarticular tibia fractures. The final research lesson, the numbers don't tell the whole story. Your interpretation of the data, your clinical expertise, and your experience matter, okay? It only helps us get closer to the truth, but how that applies to patients varies. And I think actually Dr. Makarewich's lecture is a good example of that. There's almost no trial that you could do to show that amputation versus limb salvage is better that you would always follow, right? It would always come down to some of Dr. Makarewich's expertise, some of the patient's preference, and a mashup of the two. So just to recap all of the things that I hopefully taught you today, study sizes and everything, but big numbers are helpful. They let us investigate rare problems or detect small differences. There's always something to learn from research. Think big, no problem, no question is unanswerable. However, your study outcome or treatment data needs to be relevant, right? And the numbers don't tell the whole story. Use your expertise. Which brings me back to why we do research. I do research for my patients, and I think everybody agrees with that. And I would submit to everybody as they move forward in their career that you shouldn't let the allure of promotion or tenure or publication number take away from that and take away from your opportunity to do research that means something to your patients. So if other people need help with studies that's going to change practice, it doesn't matter where you end up in the authorship list, right? Because you're helping patients, and that's what we got in here to do. So help people when you can. Absolutely get credit for the work you do, but certainly help when you can. And that's all I have. And again, I'm giving this lecture at some point in the future again. So if nobody has time to chime in with comments, I'm happy to take some via email or phone call.
I want to thank you. Great talk, very clear. I think when you give it again, you might consider explaining what confidence intervals are and how they're derived, because I'm not sure everyone understands that and how to interpret it.
Awesome. We're right up against it. So if
and
there's no questions, we'll let everybody get to their clinical practice.
Lucas, can you hear? Can anybody tell Lucas that there is a question?
That's okay. I just wanted to, I'll send him my comments. I want the folks who are on it to understand that
I got a question.
the p-value is arbitrary.
I can't hear anybody. Maybe if I unplug my computer from this.
So is Lucas totally removed?
You might try putting your question in the chat function.
That'll take too much time at the moment.
Oh, sorry, I can hear now. Was there some questions or comments?
Dr. Saltzman had a comment, and then I have I guess a comment question.
Yeah, so my comment is great talk. When you give it again, maybe it would be helpful to people to understand how you interpret confidence intervals, because that's a fundamental tool, and to understand that p-values designation of 0.05 or less than 0.05 of a p-value is completely arbitrary.
Yeah, I think you could have a
arbitrary convention. It's based on, you can make it anything you want. And so you need to understand how the t-statistic is created and what that means, and interpret it accordingly.
Well, I actually was going to comment on that. I'm a little surprised Dr. Saltzman has talked about the interpretation. I guess I was going to say one of the problems that we have with this sort of research is exactly the last point you made. And I can tell you that our own academy, the federal government, insurers, and many other people involved look at 0.07 and say, sorry, there's no difference. Therefore, and you as a trauma surgeon can look at it and say, well, as I interpret it, as I analyze it, as I look at the plus, minus, the up, down, and whatever, I think it's good. But we are progressively faced with the fact that a lot of the suits don't interpret it that way. And it can have significant impacts on what we can do for patients and or what gets covered. And they don't give us much latitude to say we're going to use our own smarts to interpret that.
Yeah, I think for the most part, it's fairly rare that an adequately powered RCT ends up with a p-value that's right on the threshold like that. That's why I think that's such a great example for this talk, the Vanco trial. But you're totally right. There's no real way around that other than through education and having people understand what a p-value means, as both you and Dr. Saltzman are alluding to. But certainly when there's a gray zone or a borderline p-value, your kind of interpretation of the data and your own experience probably play more into understanding what that means for your clinical practice than a slam dunk p-value of 0.01 or something along those lines.
Well, thanks, Lucas. Unless there are any further comments, I think we're running over here. We should probably call it. Really appreciate your talks today, both you, Lucas and Chris.
Thanks.